Good evening, everyone. Welcome to session 7 of the program. And the topic of discussion is very interesting and very important, very relevant. And that is, how do you go about de-escalating a situation? That is, how do you go about managing aggressive patient party? I think this is something we are experiencing very often in healthcare setup. And there's a realization that all of us should know. First of all, how do you really uh, prevent or avoid such things from happening? And in case if there's a risk, how to identify that there's a possibility of violence or aggressive reaction? And unfortunately, if this happens, then how do you handle it? So today's session is going to be all about how do you identify the red flags and mitigate them at the earliest. And also, in case, in spite of all the efforts, if nothing works, how do you go about managing that situation? So, to start with, I would like to know from all of you, how many of you have personally managed an aggressive patient party? Raise your hand if you have managed. Dr. Manjusha has managed, Shobhaji has managed, Santosh sir has managed. Lovely. So, a lot of people have managed. So, would you like to share your experience one by one? So, I'll start with the Santosh sir first. Uh, and then
It really depends on the situations. Many times just by changing the environment, taking the patient away from the scenario and giving a glass of water and then understanding what has triggered to that. So those things will actually solve.
So I just wanted to know the incident that happened, because if you can share your experience,
So
what happened?
I'll give you one incident which happened, which comes to my mind recently, that Mr. one of the politician member of parliament, he's known for aggression and all that. So he came and he started that hospital did something wrong and all that. And then again, he give me the medical record of the cases. The hospital did not care about properly and all that. And um, you might know also, the one of the staff, that person was not aware that we cannot just share the
Mm.
patient file to anybody just like that. So he was about to go and give the medical record, access to medical record. And then suddenly I came to know. So I went and I said, look, first and he was in the main lobby. So I said, look, first let's come and sit in my office and then we'll discuss about that. And then when he came to my office again, I said, look, patient details cannot be shared. I understand you might have some misinformation, or you might have been feeded that something has gone wrong. So we can explain to you, but even if I give you a medical record also, it will not help you also, because there are a lot of technical terms which you may not understand. But we can brief you what happened, how we handle the cases and all that. So those guys. So with him, it happens twice during the COVID time and all that. So in both the cases, what I did is that took him away from the place where because the politician always want that before the crowd, they want to showcase that yes, they are talking for their interest. And all that. Those are the things that it really helped me. And yeah.
Thank you. Thank you for sharing your experience. Dr. Manjusha, would you like to share your experience?
Yes, ma'am. Multiple times this happens because I work in pediatrics. One incident very recently, what happened was we had a 1-year-old baby with dengue fever, and he was not taking anything orally. So we were forced. We usually do not prick without reason. But then, since the child was not feeding at all, not even breastfeeding, we had to put in a cannula. And this cannula was put in the morning. The mother, despite we isolate them, there's a separate room for such patients. So we've been going in and out and telling them, see, you'll have to take care of the cannula, because the baby was very fussy, and they were not initially very happy with the fact that we were going and monitoring the child every hour or so, and they were like they said the baby was cranky because of that, but then we were forced to do it because the baby was admitted with warning signs. And by evening, unfortunately, he had a swelling at the cannula site and
Mm,
features of early phlebitis, which is not very common for a fresh cannula. The cannula was put in the morning. By evening, there were the features, probably because he had dengue also.
mm,
The parents, the father, he came and alerted the nursing staff, and the nursing staff there, her behavior, she's a very, she looks very indifferent. She's a very capable lady, but her,
mm,
the way she behaves, you feel that she's indifferent. So they felt, and they started shouting and making a big scene, and at last took the baby from the hospital. So I was on duty, and I was in the casualty when this happened.
mm,
And I came from the ED, and I had to speak, and they were only concerned about that particular behavior, that the
mm,
nursing staff did not, like we mentioned the other day, nursing staff did not attend to the baby when she was told, and it's because, and it's the same nursing staff who had inserted the cannula
mm,
early in the morning.
mm,
So they were pinning it all on her, and uh, what I had to do is I had to, bring the caretaker, the father. I gave him a seat, and then I spoke to him about how this could have happened. And obviously, I had to tell them that we'll look into it and see what can be done, and whatever we are doing is in the best interest of the baby. But then ultimately, he was not happy with that. And I found it a bit difficult to diffuse because, yes, that had happened
mm.
despite him, coming and asking the staff twice or thrice, she was engrossed in something else. So
So she didn't attend. She could not attend on you know.
she could not attend to the patient, and the fun fact is, this particular patient, after a month or so, he happened to see my junior resident at a bus stop, and
Mm,
then he came to him, and he was telling her, I remember you were there in the treating team and all that. And he was still, talking about that incident, about that particular nursing staff, how she behaved, and because probably they have taken it to heart.
yeah,
And
they must have been very upset. Yeah, I understand completely. Thank you, thank you. Shobhaji, would you like to share your experience? Because I know you would tell us more about how you handle with nursing situations. Go ahead, please.
Mm. So, this particular incident happened couple of months ago, ma'am, but still remember this because of its significance.
Mm,
So, 79-year-old female was admitted to a critical care unit under internal medicine and gastroenterology with she's COPD case and some gastrointestinal issues also.
mm,
So she stays with her brother in Hyderabad, whereas her daughter and son are in Saudi Arabia working there. So after 3 days of her admission, we received a complaint. Not me, my boss has received, unit head has received the complaint, and we were called, all HODs were called to boardroom to address that. So when we heard that, Biju very well, ma'am. He always asks us first to listen actively what actually there are. So we listened to her concerns. Actually, I have done my homework and came what went wrong there. So it is the basic. Her concern was that nurses were not attending.
mm,
The doctors were not there with her mother,
mm,
and the security, actual reason is security was not allowing her inside,
mm,
apart from the visiting timings.
mm,
She's like insisting, I came all the way from Saudi, so I want to visit whenever I want. So the
mm,
security was very much strict in that, and he said, these are the consultant timing, visit timings, that, this, and he was stopping. So that actually irritated her than the clinical. But how she can project is she was waiting for an opportunity. On third day, she noticed when she visited that there was no nurse and there was no doctor. It's sitting there next to in the cabin in the nursing station. Nobody was there, and uh, alarm was ringing continuous monitor because the saturation probe got moved
yeah,
from her finger.
yeah.
So that is, oh, my mom's BP was fallen down. Nobody's noticing all that, and she started shouting at us. Then my boss told us that Shobha and Ajit, medical head, you both handle this.
Mm,
So I told Dr. Ajit, my medical head, also to leave. I'll take care. So I promised her I'll be shifting her. We have another critical care wing. I'll be shifting her there. And second day, third, and every day I was visiting her mother morning, evening, and meeting this attender also just to say hi, hello. And from sixth day, everything got changed. But one thing which mother noticed was, though I changed her department area, but the nurses were same. I have given particularly the same three nurses who were handling in MICU 1 also to this place, which mother note. Then she started telling, in MICU 2, they took care of me. Nice. Though they didn't, they were taking care same way in the MICU 1 also, but in MICU 2, she was saying that I noticed, Shobha, you gave me same nurses and they were doing a wonderful job. And the security also I changed. MIC 1 ka security only I put it in MIC 2 with the help of CSO, which attender did not notice, which I have to tell them. It is how we perceive that day.
Yeah.
And we have given some extra permission of visiting the mother maybe 2 more times, and I have given the time. These particular, apart from the visiting hours, these are the timings you will be visiting along with my nursing supervisor, not alone. So that I have ensured. With that, she was happy. But the people, only place got changed, people are saying. So even now, she's in touch with me, ma'am. She keeps messaging me. So that way.
So I think, Shobha, there's a lot of learning from your experience. So I want others to tell what is your learning from the way Shobha managed that situation and de-escalated and also made the patient and her family satisfied. And what were the genuine concerns? I think that part also need to be, closely noticed, that not all complaints by the patient are ingenuine or very trivial. They could be very genuine. For example, if the alarm was ringing, to you or to me, it might appear, oh, it's okay. It's just SpO2 or just a BP fluctuating. But for the patient's family, alarm in the ICU means something very serious. So what are the couple of immediate learnings that come to your mind from the incident Shobha has shared with us? Very briefly, just to the point, if couple of you would like to unmute and speak, but keep it very short because we can't discuss this for very long. So what's your takeaway from her case?
It needs a lot of patience, ma'am,
Okay.
to understand and listen their actual concerns, and so that half of the job is done when somebody is keeping attention at the top level, so that
Wonderful.
somebody,
Mr.
the hospital
Anand,
management is concerned about it.
yeah. Thank you, Mr. Anand. I think that's a wonderful observation that you brought up. Thank you for that. What do others say? Suvira has written in the chat box. Let me read. It says, create visible change. Yes. So that means they should feel that, yes, you have taken some corrective action, some help you have tried to provide. Yeah. Poonam has mentioned empathy is very important. Absolutely. I think that's one of the most important virtues. If you will look at the situation as though the patient is just simply making fuss or it is nothing very big, definitely you will never be empathetic. You will actually somewhere be judging the patient for being unnecessary trouble to the medical or nursing fraternity. So very important. I think empathy is very important. What else? There are some more answers I can read. Kumar Reddy says need to keep a lot of patience to listen to things they react according to the people. We can solve. I think that's one of the very important things. Patience is very important. The problem is the moment we come across a person who is not very well behaved, we also get disturbed and overwhelmed and we start reacting to it without actually understanding it's not my problem, it is his problem that I'm here to solve. But
if we
yeah.
react suddenly, ma'am, they
Yeah.
will react like anything. They will blast us.
Yeah.
Whatever
So,
they'll tell, we need to listen them, and
yeah.
we need to take up a call according to the situations, so that we can manage the things in a right way.
Absolutely, yeah. So Anju has written critical thinking to resolve the issues. Absolutely, Anju. And if you are well prepared, and if you know these kind of situations you will be facing, these are very regular things. These are not big things. Why not all of us be ready to handle such situations, have answers for those questions, have solutions for those questions between us as a team? If we know that, okay, if there's a patient who is needing more attention or has more concerns, we all have to collectively handle it without losing patience, without losing composure, without blaming the patient. Why not come up with that approach? I think that's also a very important aspect. Suvira has written personal involvement. Absolutely. I think that's very important. And that's where patients really value your input, that you took action, you took care of me, you modified things, you customized things. Very important. Good communication. Absolutely, Dr. Mandisha. Somebody's device is on unmute. Can I request you to mute your device, please? Okay. Parvi has written, understanding the situation of a relative and making provisions to accommodate their request if possible, as some relatives are sensitive and need to be handled differently. Absolutely, I agree with you, Parvi. At the same time, for example, Shobhaji, you were talking about that patient attendant who had come from a foreign country to visit her mother. Now, the moment you hear that my mother or my father is unwell, just tell me what is the immediate thought that comes to our mind, and especially if they are elderly or they are senior, in age. I think the immediate thought is, will I get a chance to meet them? Will I be able to see them? Will I be able to talk to them? So I personally always tell all healthcare professionals working in critical care area, please keep this in mind. And a lot of time, no, we become very strict on it. Please visit only during visiting hours, which is all right. I'm not saying it's wrong. But at the same time, we should be able to evaluate if this person has come for the first time and has come from another place and is wanting to meet his or her, family member. We have to accommodate that. What, unfortunately, if the patient dies before the next visiting hours? I will be depriving the family members from meeting or seeing their patient, when they were alive. So we need to be really very sensitive to their needs and see how we can accommodate their. That's called patient-centric approach. Earlier, we wanted everybody to, align with the hospital policies and hospital functioning, but now we try to accommodate how we can make patients and their families more comfortable and, felt more looked after. Relationship building. Yes, Aarti, absolutely. I think that's very important. And that's what people remember. I think both Dr. Manjusha and Shobhaji mentioned that after getting discharged, the patient still remembered. And if you are able to create that kind of rapport, they will always remember you. And see, even these people could not forget. Shobhaji also could not forget, like she's saying, it's like 5-6 months ago that happened. That means even we remember those incidents either as painful incidents or as good incidents. And then why not create good memories, which when we remember, we feel good about? Absolutely. Priya has written, active listening is most important to the patient. Absolutely. I think if you are able to do that, and when we say active, it's not that we are pretending that I'm listening. Every small thing that they offer, and if you are able to talk about that and mention that and resolve that, they feel very valued that yes, my words have been taken seriously. Dr. Manjush has written, usually we tend to be in the role of that role that is assigned to us, indifferent of what the patient or bystander is going through. I think that's very true, and that is why people are unhappy with us. We are doing our job, but emotionlessly, in a very mechanical manner, and that's what is really upsetting everyone. Deepa ji has returned, she took personal care and attention to the problem, proved that same team took care of the patient very well. Absolutely. And quite possible, Shobhaji, even if you moved that staff to the to her care, even if you move the care area, I'm sure even the staff must have realized the importance of being more responsible, more proactive, and not letting the patient feel being neglected or not looked after. And your intervention, I'm sure, must have been taken seriously by your staff, because they know that if you are involved, means they have to make sure that they don't disappoint you and also don't mess up with the things. Absolutely. Making special provisions. Yes, Suvira, I agree with you. And that's actually going out of the box and thinking, how can I make my patients? Then briefing will help them. Absolutely. So that means even between us, we should be on a common platform, and everybody should be knowing what we are doing, and not with the idea that, I mean, at the back of the patient, we are talking poorly about the patient, or we are complaining, or we are blaming the patient, oh, they are very aggressive, they are very rude or very demanding. Not with that approach, but between us, we decide, okay, this patient requires more attention, more time, more input. Let's arrange, let's do that. And then knowing of condition, diagnosis, and prognosis also help to brief and counsel the patient. Absolutely, I think Dr. Santosh, you have really nailed a very important point. I think I shared this earlier also. My father had his bypass surgery in one of the very premier, hospitals in Delhi. 2-3 days after the surgery, he had hospital psychosis, and his behavior changed. He was very aggressive, very rude, very abusive to people. Why couldn't the hospital staff, of course they diagnosed, I'm not saying they did not diagnose, they even put him on antipsychotic for those couple of days. But why couldn't they understand that this is not the patient who's behaving, this is the disease condition that is behaving, and we don't have to react to it. They were laughing and they were teasing and they were annoyed about this situation. Can we cut that down? Can we remember that this is part of recovery? This is part of hospitalization. We can't react to every situation in an unprofessional manner. Thank you for bringing that up. I think that's a very important learning. So I think from Shobhaji's case, we all had a lot of ideas to understand how we can prevent things from going wrong. And timely intervention can definitely control the situation, and a lot of situation can be managed in a very, very healthy and amicable manner. Absolutely fine. So from this learning and from other learning and the other cases that Dr. Manjusha also shared with us. By the way, why do people get angry? Write in the chat box. What are the common reasons why nobody comes from home thinking that I'm going to act aggressive today? But then why do people become aggressive? Okay, no communication. Then there is no communication from our side. Situation, of course, definitely I agree. When their expectations are not met. Thank you, Rose, that was good one. Underlying worry and helplessness, very important, Dr. Purnima, very, very important. And this sometimes we are not able to identify. Patient never vocalizes this. Can we, think from the patient's point of view, anybody who is going through rough patch will feel helpless and will be apprehensive. And then, of course, lack of patience, expectations not being met, not kept in the loop, frustration, helplessness. Absolutely. Very right, Pauravi. Fear and pain. Absolutely. These are two triggers, we normally do not notice, we don't acknowledge, but they can be real reason for anybody becoming aggressive. And apparently patient might appear very confident and very strong, but there's a possibility that they're actually going through a lot of fear, pain, and uncertainty. Helplessness, very true. Again, the same thing, Aparna, what you mentioned. You feel you are educated, mobile, active, professional, and suddenly you are on bed. Your whole behavior will completely change. You will really start behaving very differently. That's because you feel so helpless, yeah. And when they feel uncared for, yes, when their care is not to the mark, helplessness, lot of they have written. That means that's a real reason. Financial stress, absolutely. I think that's another important point. Sometimes, even if they can afford to pay, I think nobody has spare money kept for medical intervention. Nobody likes to keep that kind of fund. So it definitely causes a lot of stress. But in any case, hospitalization has become so expensive, treatments have become so expensive. for a middle class to get it admitted into a good hospital and pay without insurance cover can be a hell for them, can be a real help. Then assumption that the patient or the family understands changing conditions. So, Kausar, we are talking about why do people, that means patients and their family members, why do they become aggressive? That's the question. So probably this is, you're talking about the healthcare professionals, why they become angry because they assume that the patient and the family understand that. Financial stress, yes. And they are already disturbed with the disease condition, and if their needs are not met, they're very unhappy. Absolutely. Lack of certainty, yes, we have talked about. Fear of losing life of loved one, very important. I think that completely changes a person's mental balance. Anybody can go. I mean, I don't know how many of you have personally seen this, but I have seen, personally myself and my family members. I mean, when we had a couple of deaths in the family who were very very close to us. Even I lost my balance for a couple of minutes and I was not able to think wisely. And you're right, that's very common. Poor staff behavior, yes, I think Priya, yes, that's one thing very, very important. Poor staff behavior and attitude, and especially if we appear indifferent to their pain, their suffering, their concern, they're very, very unhappy. The felt need differs from the person to person, situation to situation, and our response should be customized. So that means we need to be more sensitive to understand what the patient needs at this moment and what we need to. Absolutely right. I think there are so many things, that could be visible to us or not visible to us. We are not even able to sometimes see, which could act as a trigger. I don't think anybody comes from home thinking that today I'm going to hit a couple of people and I'm going to smash them. But when things happen the way they don't expect or they are not up to their expectation, that's where uh, they just lose their balance. So, what challenges have you experienced while handling aggressive patient part? Again, write in the chat box. Yeah, fatigue is also a trigger. It could be on both the sides. I agree with you, from the patient and the family, and also from the healthcare professional. But of course, fatigue of the patient and family is very understandable, especially if the patient is uh, admitted for very long under our care. Yeah, workload again. Again, what you're talking about workload is probably, Dr. Santosh, our workload.
Yeah.
But I'm talking about the patient and the family getting angry. I'm talking about that, but I understand what you're saying. Yeah. So what challenges have you experienced? I can see some answers coming in the chat box. Uh, Difficult to make them understand. That's a very important point. I think that means we try to communicate, we try to counsel, we try to explain, we try to educate, but still things don't work. That means there is some gap in the way we are explaining, the way the person is receiving. Communication gap, yes. Again, similar thing you have mentioned, Mr. Kumar. Then Dr. Manjush has difficulty in convincing the bystanders when actually an error has happened. Very important, I think. Uh, and that's where actually the communication breaks down, because there are always people who will be just very aggressive and not ready to listen to any explanation. Time pressure is another reason. Safety is another reason. Priya, very right. Safety of self, of your team member, and other patients, bystanders, absolutely. And then sometimes mob mentality. Yes, that's another big challenge, especially when you are not prepared for something like this and something like this happens, it becomes very challenging to handle that. So I'm taking you through the presentation. The first focus will be why do people become angry? And I was going through some material to look for why people become angry. And I came across a very interesting article, which I'm going to share with you, which really explains the person's psychology. It could be patient, their family member, or even your own team member. So if we can go to the root cause and see that this is the reason why people get angry, can we prevent them? Can we avoid them? Can we manage them? I think that's the idea why I want to talk about although, I mean, no amount of explanation can justify aggressive reaction. I'm not endorsing. But if we understand that these are the causes, can we prevent or control this situation? And then crisis never happens, all of a sudden. There are always red flags. There are always, indications. How smart are we to identify? How well trained are we? How much have we trained our team to identify those red flags and report and escalate and take timely action? Is another area that I want to discuss, so that you take this session from here to your place of work, wherever you are, and discuss with your team that these are the red flags. And the moment you see this, we need to report, we need to escalate, we need to take a corrective action so that we can mitigate the situation. So, with this approach, let me share the presentation with you and take you through the slides. Okay. So, as I said, that I was trying to understand why do people get angry, and I came across a very interesting, article. This article is by Mark Gorkin, who says that there are four phases of anger that starts from four eyes. So, very interestingly, he has mentioned. So, whenever somebody has a palpable sense of injustice or injury or invasion, there is definitely an intention to challenge the status quo. So let's understand each one of them in detail. The first angry eye, that is injustice, actually is when the patient or their family member see themselves as a victim of an injustice, unfairness, or disloyalty. So whenever the patient or their family, whether it is true or not true, that does not make a difference. But whenever they will have this feeling that we are victim of a situation or we are not being given a just treatment, and somebody has been, unfair to us, there is a possibility of people getting angry. So some of us might say that no, that does not happen in the hospital. We never ill-treat people. We don't do that. But lot of studies have shown that patients experience lot of injustice and unfair treatment at our hand. So this is one study on elder abuse, and it's a self-report by staff about the prevalence of elder abuse in the institutions, something like nursing home. 64% of the patients actually experience, elder abuse in the senior living. Then 33% have experienced psychological abuse, 14% have gone through physical abuse, 11% of the patients have experienced neglect, and even almost like 2% of the patients have experienced sexual abuse. So female patients, patients with cognitive impairment, and patients older than 74 are at higher risk of abuse, according to this study. We have seen lot of, reports, although we normally curb those reports, we don't like those reports to come out, but we have seen patients have been sexually abused in ICU, where the patients are not very alert, not conscious, and there are staff members going in, going out, and everybody assumes that they are hospital staff, so they will not do anything to the patient, they will not harm. But that's not true. Just recently, I'm sure some of you must have read in the news about airlines crew getting admitted into an ICU for some reason, and she complained of being molestation, by the hospital staff, which nobody believed initially. Nobody agreed. Nobody believed. Everybody thought that she was not probably in conscious, so that's why she's talking about that. But once they went through the CCTV recording, it turned out to be a truth. Even children in the pediatric areas, Again, we have seen lot of cases where kids are abused by the hospital staff. And I'm sure you will agree with me. We just cover up those kind of things because we don't like to talk about that. But the reality is there's a lot of such incidents happening in the hospital setup. Another study where they talked about the mistreatment that the women go through during childbirth. I'm sure, I think almost all 100% of the women go through, trauma, birth trauma during delivery. I think you'll agree with me. But this study showed almost like 57% of the women reported some or the other form of mistreatment during childbirth. So we may say that we hit the patient because we want the patient to push, or we want the labor to progress, and we want quick delivery. But that's not the way. You can't hit people and make them, deliver faster. Then this is another study that says almost every woman goes through some level of disrespect or abuse during childbirth. Again, the same point that we might think that during childbirth, hitting women or talking loudly or being disrespectful or even ridiculing them is something which is okay, but which is not true, And the problem is not just in the developing countries. Even the developed countries have similar trend. I remember I was reading an article by one of a very famous celebrity, and she did write about her experience that she kept complaining of some condition to the healthcare providers, but nobody took her complaint seriously, and ultimately she developed some complication because of that. So this is another study where they kind of and it's a simultaneous study done in New Zealand, US, Australia, and UK, and they identified 6 types of mistreatment that women have gone through, and primarily are about failure to meet professional standards of care, specifically being neglected and abandoned by the healthcare provider. And we know what a safety hazard it is when you leave a mother or a lady in active labor alone. I mean, what all can happen, you can imagine yourself. So the second I is, just 1 second, I'm not able to, yeah. The second I is injury. And again, whenever the patient or their family members, they can see that the patient has experienced harm at the hands of healthcare. For example, you are trying to insert cannula, but if it is being done by somebody who is not really very pro at it, and if it is done by some trainee, definitely the family is not going to take it lightly, and they are not going to be happy about it, because nobody likes to be, experimented. So if you say that, I mean, it's my trainee who did it, whatever it is, they are not going to like it. Or when they feel that they were, disrespected, discarded, or ignored, or their complaint was not taken seriously, or they were not attended promptly, again, they will feel that they have experienced, not only insult and humiliation, but also injury. So if you look at the harm that we are doing to the patient, I think the report by WHO gives us a very beautiful overview of the harm that we are doing to our patients. According to WHO, every 1 in 10 patients experience harm while receiving hospital care. So we can't be proud of giving very safe care to our patients. Half of the harm is attributed to medication. So it could be prescription error, it could be dispensing error, it could be, when the medicine is being actually given to the patient. Could be wrong route, wrong medicine, wrong dose, it could be anything. Then 10 out of 100 patients acquire infection from the hospital. Infection they did not come with. And approximately 12.7 adverse events happen for every 100 hospitalization. Patients' fall rate is 3 to 5 per 1,000 bed days, and more than 1/3 result in injury. You can well imagine that means if you have a 200-bedded hospital with full bed occupancy, so in every 5 days you can expect at least one serious. Am I right? So that's the risk of fall that the patient. It could be in the toilet, it could be, from the bed, it could be anywhere, but then that's what happened. And then 5.7 to 8.4 million deaths due to suboptimal quality care. So I'm sure these are never reported as deaths due to medical error, but they are nothing less than medical error. They are nothing less than medical. And then more than 50% of the harm is preventable. I think this should open our eyes to the fact that we are doing a lot of harm to the patient. Yes, Dr. Mandisha, you have a question I think to ask or something to say.
Yes, thank you, ma'am. Ma'am, my question was the figures are alarming and concerning, but if we have, uh, probably they meant that our care is not up to the mark. But isn't it mostly because the resource is lacking? The patient doctor ratio, or the nurse doctor ratio, or even the housekeeping ratio is just it's really bad because here in Kerala, especially the government setups, you have 120 patients in a ward of 60 with 4 nursing staff for care. So how are we expected, or you have a doctor sitting in the OP attending to 200 patients? How are we expected to give quality care in such settings? So I think that also plays a big role. You don't even have time to talk to the patient.
I completely agree with you, especially when there is a resources crunch and there is manpower crunch. These problems are very, very likely to happen. I completely understand. But these figures are not just from the developing countries. Even in the developed countries, where there is no, dearth of resources or the manpower, errors are still happening. That
Yeah.
means that means, of course, shortage of manpower, shortage of resources will definitely cause a dent. But if we can look after the other areas, can we reduce the number of errors? That's why. Yes, Dr.
Can I?
Sharma, please. Yes.
Yeah, ma'am. So patient safety is one of my area of interest. I work with W2 Geneva on the Department of Patient Safety. And you rightly said that it is not only with the low income countries, it is all about even the developed countries like America, Canada, Australia, England have a similar kind of standards. Even and in India, maybe reports are not, we don't report it. We have started doing, but still we are not sure about the data.
Absolutely.
So just one point and 2 points I want to make. One is that 17th September, just to prevent that World Health Organization celebrate the Day of Patient Safety every year. And this year theme is about the mother and child health care. The second thing is, of course, and majority of the regions are not with the resources, but about the systems.
Mhm. Yeah.
So if you are take care of the, if you have a robust system in the organization, then probably most of these things will be taken care of. Just
Thank you so much
briefly, I
for
wanted to.
Thank you. Thank you for being there. So, Dr. Mandusha, at this point, although I would be digressing from the main topic of discussion, but what I want to say in the government setup, it is not somebody's device is on unmute mode. Can I request you to mute your device, please? Thank you. So in government setup, although I know there is a resource crunch, there is a, so lot of time it is disproportionate, distribution of resources and underutilization of resources. Even the manpower, whoever are there, are they trying to find out ways how do we really arrange things in a manner? Mr. Vimal, is your device on unmute mode? Somebody's device is on unmute mode. Let me, I will have to fix this. Give me 1 second to mute it. Yeah.
Ma'am,
I don't know whose
Mr.
device is on
Patel.
unmute mode.
Ma'am, I think it's Miss Anju Bhatt's.
Yeah.
Oh, okay. I muted her. Thank you for. I could not see whose device is on. Thank you. Yeah. So again, I'm saying creatively, can you see how you can, compensate for that? For example, if you educate the patient family member, the message from WHO about patient safety is educate patient, educate their family. There can be no better person to ensure patient safety than the patient themselves and their family themselves. But are we ready to engage them? Are we ready to educate them? Are we ready to answer their questions? Are we ready to explain them? Then they become completely lay person for us, and we are not able to utilize that resource. Patient education, family education is one area that can give you a lot of support wherever we are working. But I'm sorry, I will be closing it here because I know, again, that's a very interesting topic, but then we will be digressing from the topic. But the problem is, yes, this is not just in developing countries, it is across the world that this is the situation. That means there are some more reasons for this kind of a situation. The third angry eye is invasion. So, see, being away from your comfort zone, from home, from your bed, away from your bathroom, away from your, it's itself is a very, uncomfortable arrangement. But if you are in a hospital and anybody can come in and go out in your room or in near your bed, that also gives them a feeling of, their freedom, their autonomy, their boundary is being constricted or disrupted or violated. A lot of time the patient is being examined per vaginally. We have seen this happening. And there are other staff members walking in and out of the same area. Even in the labor room, we have seen ladies, almost lying fully naked or half naked. And then there are people who are walking in and out of the labor room without even realizing how uncomfortable it must be for that lady to lie down like that. So this experience can be very traumatic for anybody to go through. And then when they feel their identity and their integrity are being threatened. See, patients are educated, well off, professional. When we treat them like you don't know anything and we are the one who know everything, and their identity is completely, not even acknowledged but also threatened, definitely they feel that, I mean, we are being invaded by healthcare professionals. And there are a lot of studies again to talk about that. We have talked about childbirth. A lot of ladies have mentioned that they felt that the privacy during the childbirth process was not up to the mark. There was lack of privacy. Even psychiatric patients, in the interview, they have mentioned that they felt there was a lack of privacy and confidentiality during the consultation. And we know, especially in government setup, we have seen not just one patient with the doctor. There are so many patients and attendant, surrounding the doctor's table who are overhearing the conversation between the doctor and the patient. So, I mean, this is something very, very common that we have seen. So the last angry eye is intention. So whenever there is, injury or there is insult or injustice and there is invasion, the last angry eye comes into action, and that is intention. So by then, the person has actually accumulated or generated energy to challenge it, to do something about what they are going through or what they have gone through. And that's where they decide to challenge the status. So before actually something like this happens, it's very important that this is where we can play a very big role. Can we identify the situations and patients where there's a more likelihood of aggressive reaction? So can you tell me some situations where you can expect uh, aggressive reaction coming from the patient or the family? Right in the chat box. ICU, yes, critical care area where there's a lot of uncertainty. Risk prognosis is poor, definitely. And if you have a young patient admitted, ED, another area, absolutely. Again, a very emotions are high, risks are very high. Okay, whenever there's confusion, pain, or discomfort, because they're very right. I think this is what I was looking for. When the person himself is in pain or is a lot of discomfort and confusion, person can act aggressive. Then delay in attending in ED, security not letting in, and the close relatives are not counseling. Yes, that's another reason why. Lack of response in night. That means nobody's attending, that promptly like they would do during the day. Pregnancy and childbirth problems. Yes, if somebody is in labor pain, I remember in one of the hospitals, the lady actually had false pains, and the lady's mother-in-law was with her. The man was outside the labor room. The resident knew that it's false labor and nothing much to be done, but she failed to communicate to the family, counsel them properly that it's just false labor pains, nothing much to be done. We are just hoping it to settle down. The lady went out and she told the her son that your child and your wife is going to die because nobody's attending to them. This man comes in and starts fighting with the resident. He literally, slapped and tore her clothes. And what was the reason? Communication gap. If the family had been counseled, probably this could have been avoided. And especially in obstetrics, emotions are very high, expectations are very high. There's a lot of mixture of emotions. So you can expect extreme reactions coming from the patient and their family. Behavior of the staff, very right. While being taken for test and procedure, that means again there's uncertainty and there's a concern. Overcharging, yes, that's very important. Whenever there's a bill that is not justified, there can be an aggressive reaction. Waiting time, surgery waiting time. If somebody is waiting and you have not informed how much time will it take, for how long you have to wait. And then all of a sudden you say, sorry, your surgery is cancelled today. Expect a argument coming from them. Transfer from one care setting to another, and underlying feelings of vulnerability. Yes, especially, for example, the patient does not want to go to the ward or to the room, but you are insisting on moving the patient from ICU to room. Maybe they will feel that we are not we are not getting the attention that we require. So there's a possibility they might get upset. Restraint or sedation. Yes, that's another where they will not be in their restraint is, yes, again, they are experiencing more like injustice and also injury and disrespectfulness. And then in sedation, yes, our behavior is very different. No relief of symptoms, absolutely, and especially if it is pain, fever, bleeding, there's a lot of uncertainty with it. They can react. And then bad news and unfavorable diagnosis. Thank you, Priya. I think that's another good reason you have mentioned, because you don't expect to hear something like this. And when you hear this, the first reaction is that you get angry. Besides this, there are a lot of medical conditions where you can expect aggressive reaction. For example, medical conditions like dementia, delirium, traumatic brain injury, and neurological condition. You can expect the patient to become aggressive without any reason. Confusion, like one of you have already mentioned, especially when the patient has some cognitive impairment or is under the influence of drug or alcohol, you can expect some misbehavior or aggressive reaction. And then pain or discomfort, fear or anxiety, that is uncertainty of outcome, vulnerability, and then frustration, especially if there is long wait time and there is no explanation, there is nobody to answer, nobody to explain, and they feel that they are being neglected. There's a perceived neglect or lack of information. Yes, there's a possibility of aggressive reaction. And then feeling of helplessness. People might act out just because of this, just because of this. So let's do a small role play. A role play on any situation that you want to take, and let's see how we handle it. So, any situation that you want to suggest? Otherwise, I will have to give the situation. Any situation that you have handled and you want to see how it can be handled differently, you can take that situation. Dr. Nirankar, any situation that you want to talk about? Or anybody. I'm not particularly asking Dr. Nirankar because, or Rose, if you have a situation that you want to talk about. No situation. We're handling every day such people, no? Dr. Manjusha, any situation that you want to take for the role play or suggest for the role play?
The consultant has not attended to the patient who's come with fever in the ED, fever for a day. Why? Because he was busy with a Rotax RTA patient, a trauma patient. But then this patient has been here in the ED for 10 minutes and he'll lose breath. It's something that we had last day.
Okay. So we need now 3 volunteers. 1 who will play the role of the doctor, and 2 who will play the role of the patient's family. We don't want patients. Usually patients are quiet because they don't have the energy to fight usually. It's the family who is very unhappy and frustrated with the delay in care. Anybody? जिन्होंने पहले रोल प्ले नहीं करा वो करें, then it will be nice. करो भाई वॉलंटियर, ऐसे तो हो नहीं सकता, रोल प्ले तो होगा. Why delay? Why waste time? कौन बनेगा करोड़पति? Somebody has to volunteer. दीपा जी आप बनो. You be the doctor on duty. ठीक है? बनोगे? ओके, चलो. फैमिली कौन बनेगा? थोड़ा एग्रेसिव होना चाहिए क्योंकि एग्रेशन हैंडल करना है ना. Manjusha ji बनेगी because Dr. Manjusha has seen it, so she can play the role of the patient family. Is that okay?
Yes.
Okay. So one more person. Please volunteer. आरती आप बनोगे? आपकी आवाज क्यों नहीं आ रही?
Okay, ma'am.
Okay,
Am I
great. Great. So पहले थोड़ी situation explain कर दो Dr. Manjusha एक बारी, and then we all will switch off our camera, but you first explain the situation.
So there's this 14-year-old girl who has been brought by her father to the ED at 10 o'clock at night with a history of fever since evening after she came back from school. She's got headache also. So they've tried giving a paracetamol from home without much relief, and he has been brought to the ED. When she was brought to the ED, there's a casualty medical officer is busy with a RTA patient, a trauma patient. Is busy in stabilizing the patient and referring him to a higher center. That is when this patient comes in. There is only one doctor and 2 staff nurses in the ED, and they're all busy with this patient. So he's standing there in the ED, not knowing where to go. The 14-year-old child and his father. They wait for 10 minutes, and after 10 minutes, he starts shouting at the nurses. He just barges into the treatment room, starts shouting at the doctor, accusing him of delaying treatment because his 14-year-old has started crying, complaining of severe headache.
ठीक है. So, Dr. Deepa, any information you want from Dr. Manjusha? More about the patient or the family? Enough?
Okay.
Enough? Okay, great, great. So, Dr. Manjusha, you will be the girl's mother or father? Mother बनोगे तो ठीक रहेगा.
Mother.
तो रोल जल्दी से आएगा, है ना? Mother. And Aarti will be like Masi.
Okay, ma'am.
Masi
Okay.
बुआ, है ना? ठीक है, ठीक है. So we'll all switch off our camera, and we want to see how Dr. Deepa handles the situation. Ultimately, see, this is what we have to learn from the situation. And then, in case if I feel I need to come in, then I'll have my camera on. But meanwhile, I'm going to switch off my camera. Okay. So 3 to 5 minutes are okay? Okay. Go ahead.
So, I'll give you the scene. The 14-year-old, my daughter, my sister, and myself, we have come into the ED. So we have been standing there for about 5 minutes, not seeing. We don't have anyone attending on us. So I'm just getting into the treatment room. Doctor, can you please come and see my daughter? She's got fever from the evening and she's got this terrible headache. She started crying. Can you please come and see her?
Okay. Please, just give me a second. I'm too busy with a patient who's having severe injuries in an RTA. Actually, we have to transfer him to a higher center. So we are just trying to stabilize him. Please wait. Please sit down, take your seat. Please make your child sit there. I'll soon come and see her. And I'll ask my sister to check her temperature.
Ma'am, how can we sit? Our baby is crying. How can we sit? Like she's having a severe headache. Please do something. At least send someone.
Oh, I
I
see.
think we'll do something.
Actually,
We'll wait for 5 minutes and see. She said, no?
Okay. Okay.
I hope
So
you have
we
given
will-
her some medicine, right?
We
Any-
gave her
any
medicine, but
medicine
not
for.
working. Anyway, doctor, you finish your work and come fast. We'll be outside.
Okay,
So
right.
almost waited for 10 minutes.
Okay.
Now,
I'll be soon
again,
attending.
we
Please.
just barge into the room.
Yeah, we are waiting.
Doctor, you said 2 seconds. It's been so long we are waiting. My daughter is almost dying. Can you please come and see her? She's falling off the bed. What are you doing here? Don't you have any sense? This is a 14-year-old small girl.
Yeah, at least send someone. We are waiting here.
Okay.
Are you a mother? Don't you know? Don't you have children? Is this how you take care of your child?
Okay.
And
So
now why are
I'm
you
so
smiling?
sorry. I'm so sorry.
Hey,
I'll
you're
send
sorry
one of
whom
my.
to?
I'll send my
What sorry?
sister.
Then why
Sister,
are you
please.
opening this hospital? If
Sister,
you
please
can't
check
treat
the.
patients, don't open the hospital. Close it, no?
I'm so sorry. Because we are so busy. My sisters are also so busy with this.
If you're busy, then why did you make us take an OP ticket? You asked us to pay 250 rupees. We have taken the OP ticket and now you're telling you're busy.
Okay, I'll just
Why you
send my
open the
sister.
hospital? Huh?
Please.
Every
Please.
time we have heard, when you come here, you refer or you don't treat. That is why we don't like to come here. But what to do? There's no other place, no nearby. Auntie, I told you,
Exactly.
we will not take her.
Okay.
Go somewhere
Yeah.
else.
Yeah, we should
I'm coming.
go somewhere
I'll
else.
see your patient. Please be
Ma'am, you
calm.
are
Please
saying
be cool.
same thing from so long, and we are just waiting. It's been half an hour that we are waiting. Our baby is crying again and again. What should we do?
Please. I'll just send my sister. Let her check the temperature first.
See, we have
And
not come for the sister. If you can come and treat, you come now. Otherwise, we'll show you what we can.
Yes.
My brother is in the, he is in this party, okay? I know whom to make, whom to tell him.
Yeah,
Yeah.
take
When
as
that
much.
person calls you will come and see. I know what to do.
Yeah,
See,
you can take
Call
as
your
much
brother,
money
no?
as you want,
see,
but please
Call
come
her
and
father.
check her
Let's see what he
baby.
does.
see, this is a night time, and this patient is very serious. If I leave him like that, you know what will happen. So please
Then why
give
are
me
you
Ma'am,
opening
some
a
time.
hospital only with one doctor? You should have more doctors, no?
Yeah, that's true. But at present, please give me some time. I'll just transfer this patient, and I'll be soon coming and attending your child. By this time, the sister will take the temperature, and
See, something happens to my daughter, no, you'll all go to jail. I'm telling you. My daughter is almost, she's crying in pain. I don't know what is happening to her. She's not even speaking to me now. If something
Okay.
happens to you, I'll take you to the doctor.
I
I'm telling you.
understand your concern. I know as a mother how you're feeling. I'll be just coming there. Please let the sister take the temperature at least first,
Oh,
and then
ma'am,
I'll
please
know.
Sign
take
your
as
pain,
much money as you want to take, but please come and check out the baby first.
Yes.
Then go to some other patient.
I'm coming. I'm coming. So see, my work is almost finished. I'm just coming to you. I at your child. I attend her. Please be calm. Please give
No,
her
we
some
don't
sips
want to
of
become.
water.
Aarti, let us take her somewhere else. No, you call
Yeah,
um,
exactly.
her
Like they are
father, no, to
very
call your
careless.
brother.
They
We'll
don't
go
want to do
somewhere else.
anything.
Yeah, this is not going to work. She's going to kill my daughter.
They are
We'll go.
just
See, just now my
Tomorrow
sister
we'll
told
come
me.
and complain to your superintendent. You see, doctor.
See, now my sister just came and told that the temperature is normal. So maybe she's having headache due to the after effect of fever. So please be patient. See, the temperature is normal right now. She's not febrile.
Ma'am, she
Okay,
has just
she's a
taken a
small.
paracetamol. That is why
Yeah,
temperature is okay.
yeah.
But she is
See,
crying.
yes, she's a small child. Please try to pacify her. See, maybe she's weak. She's hungry. She must not have taken food. She
Doctor,
must be weak.
I'm her mother. We know how to take care of a child. You don't teach me how to take care of a child. We know how to feed our child. If you can treat her, you treat her. Don't
Hmm.
teach us how to take care of.
Yeah, otherwise we are going to take him to other hospital.
I've got 3 children. This is my youngest daughter. I know how to take care of children. Huh?
Okay. So, see, I have finished my work. Now I'm coming to you.
I'm sorry.
Dr. Manjusha will not leave me.
So, Dr. Manjusha, you have been patronized. No, every time we have a case, you're going to act as a patient family. See, everybody's complimenting. Manjusha ma'am has to try for movies.
Yeah, sure.
No, I am going to, capture some role plays on this, and I'm going to take Dr. Manjusha as one of the artists. Okay, so we'll ask first question to Dr. Deepa.
But most of this communication has actually occurred.
Yeah,
Faced all this. Most of them.
I understand. I'm sure. Yeah. So, Dr. Deepa, when you were handling this situation, what was the inner thought process? How were you feeling inside?
Actually, I felt like I should attend the child as soon as possible. I know the parents of such children are very sensitive. But the thing is that I have the priority is to the RPA patient. So I cannot leave that patient also. So that
But
was my thought.
were you scared of the way they were talking to you? No. Because
Actually, I didn't feel.
it's not a real life situation. But what
No,
if it
but actually, I felt it's my duty to attend the child as soon as possible.
Yeah, we could sense that. But my question to you and to all others is because I mean that real emotion did not come out because even we knew that it's a role play and we are just but had the patient been this aggressive? Okay, let me ask this now to Dr. Manjusha. Dr. Manjusha, if you were since you have seen this case happening, so what was the reaction of the doctor who handled this?
Actually, I was not involved in the incident. It was my emergency physician who was involved.
Yeah.
He's actually a very soft-spoken person. If it were me, I would have maybe, been a more strict in the way I spoke. But then what he did was he took the bystander aside, told him that this is a patient who has come with RTA with head injury and bleed, and in if he's not referred at this point of time, we might lose him. And it's not that we are not concerned about your child, and then make sure that you're seen. And a bit of an emotional blackmail. If it were your relative, what would you have done? We would have also done the same thing. Everyone does the same for us. All those was also there. And at last, but at the end of the day, the bystander was not convinced. He's just walked out of the ED.
He was not convinced.
He was not convinced. He walked out of the ED.
Okay. So, Dr. Purnima, I'll come to you. Give me a minute. Dr. Manjusha, if you were there, how would have you handled? Can you showcase that?
I would have actually
I want to actually switch off everybody's video, and I want you to now talk to maybe Dr. Deepa. Dr. Deepa is now the girl's mother, and you are the doctor. Just two of you, Zainab. Yeah.
Oh,
Mr. Anand, can you switch off your video? Can you switch off your video, Mr. Anand? Yeah. Okay. Go ahead. Yeah. Dr. Deepa, now you are
Doctor,
the mother. Yeah.
doctor, my child is too weak and she is having high fever. Please come and see her as soon as possible. I'm waiting here for almost 10 minutes. Please help us.
okay, Amma. I see you have brought your 14-year-old. What's her name?
Her name is Indu.
Indu. What has happened to Indu? What
Actually,
happened
she
to
was
her?
she's having fever since evening, and we
Okay.
gave her a paracetamol, but the fever is not coming down. She's having headache too, and she's feeling very weak. And
Yeah.
she's right now she's crying, and I think it's unbearable for her. So please
Okay,
do
I
something.
understand. We are very sorry that we could not attend to your attend to Indu as soon as she came into the.
My question was, like you said, that I would have been more strict, but Dr. Deepa was acting very soft to you, not like an aggressive mother. What if she was an aggressive mother?
Yeah,
How
what
would have you
I would
react?
have told us this. Okay, we address mothers as Amma in our
Yeah,
language.
yeah, yeah.
Amma, we understand that your daughter is not well. She's got fever, but believe me, she's going to be okay. I've had my junior doctor come and see your child, but you should understand that this patient here is very critical. If I do not attend to him now, he's going to lose his life. This is not what we want. This is a hospital. We have our priorities. Yes, your child is our priority, but then this patient, if I do not attend to now, he's going to lose his life. And I am sure you wouldn't want that to happen because you would also have had such incidents in your family. So please let me attend to this patient now, and I assure you I'll be seeing your daughter within 10 minutes after I attend to this patient and send him to a neurosurgeon. For the time being, I've asked my junior resident to take care of your daughter, and I'm sure she's going to be fine. I know you're stressed, I know you're panicking, but don't, she's going to be okay. Lovely.
So can I ask everyone to come in? But Dr. Manjusha, I think this is more or less similar to what your resident talked. Probably you were a little softer and you were more, upfront and more explicit in your expression. But of course, you were not aggressive or rude, but you did explain properly. But had you been aggressive, I want to ask others, if Dr. Manjusha had reacted with aggression, what would have happened? If Dr. Manjusha would have reacted with aggressive behavior or tone, there would be a aggressive, both parties will become aggressive, and then there's a possibility of argument. Absolutely. So I think when you said your resident was not that rude, one of the reason, even if the patient went away, he could not become aggressive with the resident was because this your resident was not aggressive. If your resident was aggressive, then there would have been a fight by them.
Yes.
And even the way you handled, there was no aggression. You were quite clear and assertive, but you were not disrespectful or rude or aggressive. So naturally, the patient party could not become aggressive. This demonstrates that it is not the patient who decides what will be the outcome. It is our behavior that decides what will be the outcome. Aggression fuels aggression. If the other party is aggressive and you are also aggressive, then there will be fueling of aggression. But if the other party is aggressive and you are asserting, then you will be able to slowly calm down the other person also. Yes, Dr. Purnima, please go ahead. You had a point to make, please.
Thank you, ma'am. Basically, all that has been addressed is very, very relevant and is what is to be done. But if I permitted, I would like to add one small point of how we have to not react but respond to situations like this. Now, the situation being, Dr. Manjusha did bring up this at the end, but what I feel is that when, as a senior, you are being directly approached by the party, though you have delegated a junior to see, that has obviously not brought about a satisfactory feeling in the patient. Actions always speak louder than words. So when they approach you and they come and tell you that my child is so sick, temperature is there, whatever, yes, do placate them with words, but better would be to delegate a member of your staff and explain to them that yes, I understand your feeling of urgency. So that validates their feeling that I will be attending. In the meanwhile, I'm also sending another staff member of my team, and if you can move away for 1 minute and just pay attention, that will diffuse a situation. Aggression on our part escalates it, but also the correct response removes the situation, and they are looking for action. They are not looking for placation. They are not looking for explanations. So actions speak louder than words, and seniors, when they are approached, should be able to understand that what action to do. If they can't personally go immediately, patient is patient. Whatever the situation, each for everybody, their felt need is important. So address the felt need. If you have sent a resident, send in some backup, or else if possible, just delegate to somebody for a few minutes and attend. That will diffuse the situation completely. Thank you for the opportunity to speak.
Thank you, Dr. Putuma. But I think the problem Dr. Manjusha talked about was that there was only one doctor and two nurses. That's all. And there was nobody else, and it was night time. And of course, I think in those hours, maybe you can actually get some help from the other department, which is possible. But at the same time, how we handle that makes a lot of difference. If we can explain to the other patient the emergency of another case, probably they would understand. And if you can ask your staff to go and check the temperature, and fortunately, fever is not a very big kind of emergency. If you look at it from the other point of view, it's still manageable. But yes, definitely you should be more proactive in meeting these situations and finding a solution to the problem. That's a wonderful point. So going back to the presentation, which I was talking about, how do you really, handle such situation? And a lot of it has been covered by uh, by all of you who have done the role play. So we get fair idea that if you want to address a situation, you have to proactively identify that there's a possibility of some aggressive reaction coming from the patient party, and identify the red flags and handle it. So I'm taking you through the stages of crisis development and how do you go about managing it. The idea here is that there are points where you can control the situation, you can handle the situation. But once you cross that point, then probably there will not be much that you can do. So let's see where all we can do and what all we can do to mitigate the situation. That's the whole idea about the discussion about the stages of crisis. So the as it is always said that it never storms, it always storms before it rains. So that means there are always some indicators, some warning signs, and we should be able to identify those warning signs. And crisis moments don't happen just all of a sudden. So we need to identify those red flags as early as possible so that we can, mitigate this situation. So be vigilant. This stage is called triggering stage. So that means this is the stage where you can expect that there are some reasons why the person is likely to get angry, and the patient may show sign of increased tension, irritability, or frustration. Trigger could be pain, fear, unmet need, or perceived neglect. It could be anything. So that means this is the very early stage where you will see there's a change in the person's behavior. Person could be the patient or their family member. It could be any one of them, or maybe both of them. So you will see them actually speaking in a louder than normal voice, maybe pacing up and down, trying to talk to different people to get more information, to express their disagreement or express their doubt. But they'll try to talk to the resident, then to the nurse, and then to the other staff member, even to the guard and housekeeping staff. You will see them talking because maybe either they want to gather more information or they want to express their anger and annoyance. And they may express their doubt when they are talking to the doctors or nurses, and they may ask a number of questions. So that itself shows that it is the beginning of the crisis and the person is either dissatisfied or is doubtful or wants more information from us. So the management strategy at this point is early intervention. This is just the beginning stage. It's very important to understand that there are some things that are bothering. For example, the patient has been waiting for 10 minutes. And if I don't attend for another 10 minutes, definitely this patient's family is going to be aggressive with me. But can I address their concern by asking somebody to go and see? Can I call another doctor from the indoor or get some help from other department? So address their concern. And but before that, I think it's important to know what their concern is. So give them a safe place to express. Like you said, some of you mentioned that whenever there is somebody who's aggressive, you don't start talking to them right then and there itself in the corridor. You prefer taking them to a place so that they can sit and talk. Because when you make them sit and talk, one is, of course, they feel that, yes, my concern is going to be addressed. Somebody is ready to listen to my problem. And also they feel that we are being respected. And once you take them away from the open area, you are actually safeguarding your interest as well. Because when this argument happens in a public place in presence of others, there's all possibility that you also might lose your composure and get angry and react to the situation. So if you can see them unhappy, dissatisfied, anxious, acknowledge those feelings and offer reassurance where you kind of mention that I'm there to help you and I will help you. So at that point, it's very important to communicate and follow the process. For example, it's very important to first of all identify yourself, who you are, what your role is, and how you are going to help. So that gives them an idea. Okay, I am ICU in charge and I am there to listen to your problem and I'll try to help you. That means they know that they're talking to the right person. Okay, I'm floor in charge and I'm here to help you and I normally address these concerns. So please feel free to share your concern with me. So what you are trying to mention, what you are and what your role is and how you are going to help. And then explain the process and procedure in simple terms. I will definitely listen to you. If it is something that I can do at my end, I will definitely do it. But in case if I'm not able to resolve your problem, don't worry. I will escalate it to my senior, management, and they will look into it and they'll make sure that your problem is addressed. So that means you are explaining the process and procedure in very simple way, so that they know that it's not going to be just left after listening to it. Then, of course, ask them to share their concern. Tell me what exactly is bothering you or what is your concern. And when they are sharing their concern, it's very important to listen actively and attentively. You know, half the suffering diffuses when somebody listens to their problem attentively. For example, a patient has come for MRI. The machine is suddenly, gone out of order. They are agitated. Their concern is very genuine, but they also understand that it is not something that you have created or your staff has created. But are you willing to at least listen to them, talk to them, calm them down, and explain to them? See, the machine was working absolutely fine till last evening. Even in the morning, we did 3 MRIs, everything went well. All of a sudden, there is some, problem. We have immediately informed the engineering department, and they are on their way. That means they get an idea that you are proactively ready to take the action. But active listening, even when you know that it's not your fault, plays a very big role. A lot of time, the message, is very different from what they are saying. So the feelings behind the fact could be different. When you ask questions, you get to clarify that, and then in between, when you become silent and restate what they're saying, you get more information. Like the example Shobhaji was talking about, where she could sense that because that patient's attendant was not being allowed to visit the patient in non-visiting hours. So that was one of the underlying grudge she carried. And when she got a chance to find a fault with our way of working, she kind of took out that grudge. So a lot of time you will see that there will be an underlying reason or underlying concern, and we need to be able to identify that. So when they are sharing their concern, it's very important to stay calm and listen to them. See, a lot of time what happens, we are not agreeing with them. We may not say it verbally, but it comes out on our expression or in our body language. So please make sure that your demeanor does not show any, disagreement to what they are saying. A lot of time we feel like interrupting them, or we want to correct them, and especially we think what they're saying is absolutely wrong, and you just want to say, no, 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 what you're saying is not correct. I don't agree with you. Avoid these kind of interruptions because they are not going to help the situation. And then don't be in hurry to justify yourself. A lot of time we are overworked, we are short staffed, we have some other emergency. That explanation is not going to help, especially at that moment, because they are not in mood to listen to your problem. They are here to talk about their problem. And therefore, it's important to let them share their problem in their own words, because that's going to also help them ventilate their emotion. And at the same time, their concern might appear very trivial to you, but please don't shun away their concern by saying, that's not a big thing. You're making fuss of just a very, very small thing. The pillow is not right, the mattress is not okay, the sheet is not clean. So for us, it may not appear to be a very big thing, but we never know, the patient might be really, really very disturbed about it. So when they are sharing their concern, it's important to stay calm and let them complete what they are saying. At the same time, empathy plays a very big role. We need to look at the situation from their point of view. Again, I'm taking Shobhaji's example where she said the patient's alarm was continuously beeping. Now, for us, it may be a very regular thing. We all know this slight variation in the SpO2, the alarm will beep. If there is slight change in the BP, alarm will beep. And we know we immediately go and we push the button and it becomes quiet. But now look at it from the family's point of view. That, oh, there's a regular alarm and nobody's attending, maybe my patient is going to die. So we need to look at things from their point of view, and rather than judging them or discounting their feeling, we need to understand from where that is coming. And a lot of time, their feelings may not be justified, but those feelings are real for them. Again, that example that I shared with you, where the husband of that lady who had false labor pains, he literally came in and he started fighting with the resident and slapped her and tore her clothes. Uh, to us, we knew that the lady had false labor pains and there was no need to overreact. But if you look at it from their point of view, their immediate feeling was the fear that the patient either will die or the child will die. So we need to understand it from their point of view. And it's important to acknowledge them. So a lot of time I saw Dr. Manjusha telling that I understand your concern. It's understandable. I know even when your daughter is unwell, anybody will be very upset. So that means you are acknowledging, those feelings. And there's a very beautiful way to actually express empathy by acknowledging, and it is done in 3 steps. That is, recognize the emotion, normalize the emotion, and generalize the emotion. So when you do this, they kind of feel that you can sense their feelings, you can understand it, and you are not rejecting those feelings. A lot of time they feel that we are not accepting their, anxiety or their fear. So when you see that they are very upset and you say, I can see you are very upset, that means you are recognizing their feeling. And when you say anyone in your situation would feel that way, that means you are normalizing it, that it's normal to feel like this. And when you say you're not alone, it's something a lot of others have experienced too. That is generalized. For example, during COVID time, we have seen people going into panic attacks. We have seen people experiencing extreme anxiety. But a lot of us were absolutely fine. That means people who had a possibility of going into anxiety, attack, they would actually would be very disturbed, will be very anxious. And if we say there's nothing, there's no reason for you to be anxious. You are absolutely fine. You don't have any fever. You don't have any cough. You don't have any cold. So you're just, overreacting to the situation. So that kind of rejection or judgment or not acceptance is not going to help. But if you recognize, normalize, and generalize, they are more likely to calm down with this feeling that, yes, somebody has been able to read me right. Then it's time to apologize. So I know a lot of us don't like to apologize because we think, why should I apologize? That's not my fault. But a lot of time, the apology is for the inconvenience. For example, MRI machine going wrong. Why should I apologize? I have not, done anything for the machine to go wrong. But when you apologize for the inconvenience that they have undergone, especially if somebody is unwell, bringing the patient from home to the hospital, bringing them maybe in the ambulance or in their car, taking a leave, bringing the patient to the hospital, waiting for almost like 1 or 2 hours with all the discomfort and difficulty. And then, you suddenly realize that the machine has gone out of order. I mean, naturally, the person is going to be unhappy. And when you apologize for the inconvenience, again, you can't correct the machine, but they feel that you can sense their pain and you are with them. So, apology here has two meanings. It's an expression of compassion and it's an expression of responsibility. Of course, when you are doing it as an expression of compassion, that's more to be for the inconvenience that they have to face. But expression of responsibility when actually something wrong has been done by us. For example, I forgot to inform the patient that the machine is out of order. It went out of order last evening. It broke last evening. I could have proactively informed all the patients scheduled for MRI for the next day, informing them that the machine is not working. So we'll let you know as soon as we can call you. I mean, that would have been wonderful. Now they have come all the way from their home, and they get to know the machine wasn't working even yesterday. That's the time they're going to be very angry with you. You could have informed us, especially sometimes when the doctor is not available and they have taken appointment and they come all the way for appointment and the doctor is not there. They're going to be very angry with us because today they value their time, they value their energy and their efforts, and it takes a lot of time and energy to come to a hospital for anything. So that's where it's expression responsibility. I'm sorry, I should have informed you. I mean, that's something like where you're admitting that yes, we have gone wrong on that. How the apology actually fails. A lot of time we apologize, but we don't apologize. And we don't intend to apologize. That's more like a formality we are doing, and people can sense that. And that does more harm than doing anything. So when you say, if what you're saying is true, then I'm sorry for. I mean, when you talk like this, tell me who will be happy to hear that kind of sorry. Or there was a mistake, but this can happen sometimes. Again, I mean, you're not taking responsibility for the error. I am sorry we can't attend to individual requests. I mean, what is the point of that kind of a sorry? I'm sorry, but we don't allow visitors during non-visiting hours. So again, if I have one line answer, that's not going to work. And sometimes these things happen. Again, this sorry is not going to be of much help. So we have to be careful not to give a conditional sorry. It should be with the idea to soothe the patient, to calm the patient, to make the patient feel comfortable. Now, after apology, it's important to provide information. You have heard the patient's concern attentively. You did not interrupt. You were calm. You were listening. You also made note of a couple of points which you want to clarify, which you want to explain, or you want to further ask. That's the time now. It's more like a dialogue with the patient. So maybe you have to provide information to the patient to explain what is happening. For example, the patient is in the ICU and we are not allowing the family to go in and we are not even updating about the situation. Or for example, the patient is in the OT waiting for the surgery. The family is waiting outside the OT and it's been 3-4 hours and they have no update about the patient's situation or condition. So naturally they are very eager to know, has the surgery happened, is the patient doing well, or is the patient still waiting? So that's where you need to clearly provide information and tell what is happening and what will happen, so they get more clarity on the situation, especially when there is lack of communication from our side. They are all the more agitated because that's something they expect us to come up, on our own rather than they asking us. We have to proactively, update them on regular basis. And then whatever concern they have, that needs to be concerned. So when it comes to, addressing their concerns, so it could be something like, the mattress is uncomfortable or the pillow is, I'm just taking an example. So it's important to know what does the patient want. Is it the mattress? Is it the room? Is it the pillow? Is it the care? Is it the attention? So they may even tell you 10 problems. So it's important, rather than you providing solution, ask them, tell me what do you want me to do? How can I really make your stay comfortable? So what you're trying to understand, what is most important to the patient and what does your patient wants to be done. And then sincerely try to resolve the issue and address the concern. It's very important to make a very serious effort to resolve the issue. And that should be visible to the patient. Like Suvira said, let it be visible to the patient that yes, extra effort has been made to resolve the problem. I remember I was talking to one of the participants in the program. So he said the patient there was a very premium patient for us and had undergone a very expensive surgery, and it was a very premium kind of a thing. So the patient was unhappy with the mattress, and patient wanted a different mattress, whereas we had the same kind of mattresses across the hospital. And the patient was to stay for a good 10 to 15 days. That was the plan. He said, I mean, we tried. Now, what do? We have the same kind of mattress all across the hospital. So, what do we do? They said, let's hire a mattress. And he ordered another mattress, hired it, and they got the mattress. So, what I'm trying to say, when you sincerely try to resolve the issue, you will definitely be able to find it. Even according to a study by Harvard, there are minimum 4 solutions to every problem. And every solution should be tried at least 4 times before you give up. That means there are 16 opportunities to resolve an issue. And if you will try to seriously, sincerely try to resolve, and if they can see that you are making an effort, like Shobha explained about her case, that she moved the patient to another care area, and she made sure that she gets the best of the care. She herself visited 2-3 times in a day. So that's the effort that's visible to the patient. And then you are focusing on the solution rather than their behavior. See, usually when they're upset, they will behave aggressively. They will be upset. But can I overlook that and look for the solution and avoid being defensive or being aggressive with them? So when you are exploring alternatives, explore alternatives with an open mind, because most of the problems either can be mitigated here, or trust me, they are going to get escalated. So crisis stage 2 is escalation stage. If you have not been able to contain the problem there, you're already in crisis stage 2, where you will see the emotionality takes over logic. And you will see the person will start reacting with great emotionality, increased emotionality. There will be signs of anger, shouting, threatening language. That all calmness, composure, decency will start shedding away. You will see the person now will become aggressive, their body language will become aggressive. They may start using language that is not a very respectful or a decent language. They may even start challenging you or your authority, and they will become belligerent. So clearly, their logical mind is not now having a full control on their emotional mind. And that's the point where you will see they may start shouting, they may start arguing with your security staff, technicians, and nursing staff, because that's where they can take out their anger. And then there will be an expression of dissatisfaction, expression of disagreement, refusal to cooperate, refusal to pay. Very often you'll see they'll say, I won't do. You will have to manage. I can't help it. I'm not going to do. So that clearly shows that there is a aggression that is escalating. So at this stage, the management strategy that will work is, first of all, is please maintain composure. Usually when the other person becomes aggressive, we also start losing our composure. We lose our calmness. We start become, at least it comes in our body language or facial expression. But very mindfully, we have to practice this to stay calm in that situation, use a low but steady voice, assertive voice, avoid arguing or challenging the patient, and avoid using confrontational language. Why can't you do that? Is that my responsibility? You were told about it. That's your responsibility also. So what I'm doing, I'm just trying to be more confrontational, and that's not going to help. This is actually going to escalate the situation. At the same time, you will have to repeatedly provide them guidance to calm down because they are losing now, that calmness. So you have to tell them, see, I'm ready to help you. I want to help you, but you need to calm down. If this is how you will talk to me or to my staff, I will not be able to help you. Nobody will be able to help you. So please take a glass of water, calm down, tell me your problem. We want to help you. Everybody is trying to resolve your problem. So what you are trying to do, you are providing them guidance. And at the same time, when you say, see, this is the behavior you will exhibit, everybody will withdraw. Nobody will be able to help you. So you are kind of letting them know that this is what is expected from you. And then show them direction. For example, they are not very happy with you. They are not satisfied with your management or the solution that you are providing. So you can say, see, this is what I can do for you. But if you're really very, not happy with what I'm suggesting, you can please go and meet the, grievance officer. I'm sure every hospital has somebody who addresses such situation. They could be the complaint officers or, public relation officer or grievance officer. So you can guide them to go and meet that person. Or you can ask them to, write a complaint in case if you think you want to escalate your concern, please write a complaint and you can forward it to the senior management, or you can give your feedback. You get an opportunity to share your feedback. You can talk about it. So you're giving them direction that how they can express their disagreement or unhappiness in a more civilized manner. And then of course it's very important to assert when they are losing rationality, because if you start saying, please don't get angry, please don't shout, please don't do this, please, again they are going to further go aggressive. And if you act aggressive, again there'll be aggression fueling aggression. The correct way is assertion, where you are firm but not aggressive. So you are telling them what you can do, what they need to do, but your way of saying is not disrespectful or angry or aggressive. Then in case if you think that they are just not in control and there's a possibility that they can become aggressive and even become violent, so very discreetly you need to alert your colleagues or your security personnel for backup. But they should not be visible to the patient or their patient, because that's something that we do often and that can escalate the situation. So a couple of points that you should keep in mind when you're in stage 3 and this is stage 2, sorry, this is stage 2, but you have to keep in mind because it will not take much time to escalate from this stage to the stage where they act out. So please be aware of your body position. Never stand very eye to eye and toe to toe kind of a situation. It may not be you who is standing. It could be your security guard. It could be your junior. It could be your male nurse. But that's not advisable because that's going to actually trigger anxiety in the other person and they might react and act. So make sure that you maintain a safe distance. So approximately 3 feet distance is considered okay, and avoid standing just opposite that person. Preferably at an angle is better because you are at a safer distance. I don't know about other countries, but in our country, I always say have a table between you and the patient part. That also acts as a barrier. And another thing that I advise is follow two-door policy. Again, we don't have very many counseling rooms where you have two-door policy, but I say please have a door behind you. What happens when you see them becoming aggressive or acting out, you will try to run away from that situation. But unfortunately, when you try to run away, you have to go across them. You have to go via them. So you are actually going closer to them than going away from them. But if you had a door behind you and you can sense that somebody can become aggressive and can start, really physically hitting me, giving some good reason, you can, go out of the room and make yourself safe. So this is what I think needs to be looked after. But when you're dealing with them, please don't argue, don't answer every question, don't speak for the sake of speaking, because a lot of time we also become reactive and we start just saying something. But that's not helpful, because a lot of challenging questions are asked just to provoke you, just to make you angry. And that's very mindfully to be avoided. Rather than that, it's better to redirect their attention to the issue at hand. Rather than saying that don't behave like this is not the way to talk, take their attention to the issue that you need to resolve, and don't get into that power struggle of argument and aggression. A lot of time you will see they just want to vent, and it's okay if you allow them to vent, especially if that's happening in the counseling room where you are safe and you think there's no problem. If they want to talk or tell something, it's okay. So when you let them vent, actually their energy to fight also goes down, and you also get to know what they are thinking or feeling or what they are experiencing. But if you can't allow that to happen, for example, you are in OT or in ICU or in labor room, and that's where they are kind of shouting. So that's where you'll have to really direct them that this is not the place where we can behave like this. So you will have to please either, let's sit in the counseling room or let's sit in the consultation room. You will have to kind of direct them. So it's very important to let them know the consequences of what they are doing. A lot of time, because they are now losing rationality, so they may not realize that what they are doing or what they are likely to do can end up into something very serious and can be a legal problem also. So if you see them becoming belligerent, defensive, or disruptive, it's very important to set some limit and also let them know that this is not acceptable. This is not, the right way of dealing it. But don't promise the consequences that you can't deliver. Like, for example, if you will behave like this, I'm going to throw you out and your patient also. So that's something we are not going to do, that we can't do. So let's not talk like this. Or if you don't try to control your behavior, I will have to call security and they will manage you. Again, that's not something that we would like to do. So don't give them these kind of threats. They are not helpful. Another point, when you're interacting with them verbally, you may be sounding very quiet and calm, but your non-verbals might not be congruent. So make sure that you keep your non-verbals neutral, because especially when the person is angry, they are not listening to your words. They're actually looking at your body language. And if they can sense that you are looking calm, they are likely to, or you're looking scared, or you're looking aggressively, their behavior will get modified according to that. So make sure that you keep your expressions neutral, and then certain expressions that can actually, aggravate the situation. For example, when you say, I don't care, or I can't do anything, or that's not my fault. What can I do? That's not my problem. So these are not very helpful gestures or verbal expressions, and they should always be avoided in such a situation. Avoid overreacting. A lot of time we actually become more aggressive than the patient party and we start shouting at them. Please remember, only one person that you can control is you. So make sure, I know it's easy said than done, but mindfully when you practice this, you will be able to do this. Remain calm, rational, and professional, even when they are acting aggressive. And your response will directly affect the person's behavior. That's what I'm saying, that if you remain calm and you use assertion, your language should be firm, clear, no fear, no threat, and you say, I'm ready to do this, I can do this for you, this is something not in my hand. For this, you will have to escalate it to the senior management, and but you are not scared or you are not threatening them. So avoid overreacting, avoid actions like shouting back, banging the door, throwing patient's file, or calling security without any provocation. Even when you call security or you know, code violate is what we use for this thing. But that should be done in a very discreet manner. It should not come to the knowledge of the patient unless it's required. So During the whole situation, keep a check on how you are feeling. A lot of time, if we are scared, or we are anxious, or we are getting angry, or we feel that I can't handle it, trust me, it will become difficult for you to handle that situation. So be mindful of your feeling. And anywhere, if you feel that I am not able to handle it, you need to have somebody with you. Uh, Let somebody else handle it, or let somebody be with you on it. After this, we are in crisis stage 3. There is not much to be done other than ensuring your safety. Stage 3 is acting out, where the patient has actually lost control and they exhibit aggressive and violent behavior. You can see that they may start throwing things, they may start hitting people, they may start damaging furniture and other items. Clearly visible that now they are not in their senses and they have lost all rationality. So at this stage, they are not usually capable of reasoning. So the management strategy would be ensure safety. Make sure that you and those around you are safe, and if possible, remove other patients and staff from other area. But otherwise, at least make sure that, I mean, this whole thing, that's why I repeatedly said, do all this discussion in the counseling group so that others are safe. And if you have a door behind you, you can also go to a safer area. So at this stage, as I said, they are just not controllable. So it's important to call for help. So engage security, activate your emergency procedure as directed for your location. So whatever your protocol is, please initiate that code and call for help. Uh, Minimize interaction at that moment. Don't try to argue, explain, calm them down. That's not going to help because they are not in that listening space. So they will not be able to even understand what you are saying. Crisis stage 4, after everything is done, after they have taken on their anger, they are now kind of calm. That's when they start realizing that probably they have overdone it. Their emotions calm down, they regain their control, they realize that, okay, I did something that was not expected from me. They may even regret their action. They may even want to make amends. They may say, I'm sorry, I should not have done that. I'm really sorry for my blunder, what I've done. And they may want to apologize and compromise. Again, easy said than done. That's an opportunity where you can actually, now kind of uh, bring about a positive change, a reconnection, and resolve the issue. I haven't seen very many hospitals taking these issues to law. Although the best way to deter people is to, in case it's not our fault, I mean, legal authorities should be involved. But I know most of the hospitals try to avoid this kind of a, response. But when the patient or their family come forward to apologize, I think most of the hospitals are okay to, take that, and then avoid discussing the incident until the person is fully settled. Because uh, the moment you will restart, they will again start the blame game and they'll start arguing with you. Reassess the needs of the patients or whatever needs to be done, address those remaining concerns, and move on. So whatever has happened, that needs to be documented. I'm sure every hospital has some incident reporting format. This is a simple one which I'm sharing. I'm sure you will have something more developed one. The idea is that your report should have the following details: the name of the aggressive patient party, it could be patient or patient family member, and the hospital staff who attended the situation, background situation, how did the situation start, and then what was done in the initial stage and what you did to mitigate the situation, what was the outcome, then ultimately what did both parties agree to, what further aggravated the situation, for example, if that didn't work out, any suggestions regarding the solution or situation. For example, if this is something that's happening very often, that means there has to be root cause analysis and kappa. For example, if the wait time is too long and very now and then if you have patients fighting with the front desk staff, that means there has to be some system where the waiting time has to be within the reasonable limit. So you will have to do RCA, you will have to do CAPA, you will have to find ways how you can minimize the patient's waiting time. And also minimize these kind of episodes happening frequently in your workplace. And then of course finally signing and your contact details, so that in case if they wish to reach out to you for further details, they can get in touch with you. Post crisis, this is where I think the real learning lies. It's very important to sit and reflect, check in, how are you feeling now, what were your concerns at that moment, what could have you done differently, what should be done for future so that you don't experience something like this. You can even discuss with your colleagues, talk to them, ask them how do they handle those situations, because a lot of learning you get from people with whom you are working. It's helpful to read material to update yourself with different ideas of handling such crisis situation, and then of course attend programs to learn crisis management. I think anger management, crisis management, conflict management, these are few things we not only need to know in theory, but we should learn in practice also. Do a lot of mock activities in your setup, role plays, so that you are better prepared for the real life situation. So the carry home message is there are always warning signs. Please train your staff to identify those warning signs and mitigate the situation at the earliest. But everybody should know how to intervene or how to de-escalate the situation. Thank you. So this is in nutshell about just 1 second. I'm trying to. Okay. Managing aggressive patient party or de-escalating the situation. I know it's exactly 10 o'clock, but if you have any questions, we can take now, maybe in 10 minutes.
Ma'am, what was the first stage of this crisis life cycle?
Trigger stage. Trigger stage.
Okay.
Yes, Subira, go ahead.
Ma'am, I don't have a question, but I have an observation. I feel कि this is like a very intense chapter, and it's one that we can truly learn from, because to engage in such kind of behavior, I feel it requires a lot of humility from our end, so that we don't engage in that power struggle, naturally. And we have to sort of play that dance between kab engage kare and kab disengage kare. Because again, you cannot keep an eye for an eye, basically. You cannot keep doing that. And I was thinking about the activity that we did, the role play that we did. And I was more concerned about the patient going away. My focus was on that. And then I realized ki, sometimes it's okay, like if the patient goes away, that is not our ultimate goal ki patient ko kaise wahan pe glue karke rakhna hai. We just have to make sure that for whatever duration we do have the patient with us in our organization under our care, we try to do our best by them. And then sometimes they do have to walk away, and maybe that is the best solution for them, that they go and get help elsewhere. Like not ki tum jao kahin aur dekh lo, but if so and so happens, then we kind of have to make peace with that as well. So end of the day, even in that sense, the patient comes first. So that's something that I realized even during the activity. And most of this is highly intentional, and we have to make a lot of conscious decisions. Like towards the end, I liked that there was a post crisis area where we could reflect, where we could gather ourselves, where we could soothe ourselves. Because as much as this is about the patient, for us to be better providers, we have to make sure that we come from a space where we are high on energy, high on intentions, highly aware between one case to another, to shift gears. It requires a lot out of us. So I think a lot of what we do for our patients, we also have to do for ourselves. Only then can we be good providers for them. So
And you have to get ready for the next patient also.
yes, then get ready for the next.
And transfer your anger to this next patient.
Yes, that cannot happen under any circumstances. I mean, it's human, but of course, we have to take that into consideration every single time. So I really liked this chapter, ma'am. Thank you so much for doing this so well, and it was really engaging and amazing job once again by all actors, performers. Too good.
Thank you. Thank you. Yes, Dr. Purnima, please go ahead.
Madam, you just one small thing I wanted to say is that you have mentioned kappa, and that is very essential, just like self-reflection and where the thing is. For us to go and say that we are low on staff, why are we low on staff? In an emergency department, why have we not got provisos in place? Because there are certain things, our duty we have to do to the best. So kappa, which you mentioned, ma'am, that is something which is a must after any such incident or any such near incident also, because that is something which we really have to do immediately, and we have to keep it sustainable, because rather than intensity, the best answer is always longevity. Thank you, ma'am.
Thank you. So at this point, I wanted to bring in that example of that doctor who got killed. I think her name was Vandana, if I'm not wrong. Very young doctor who got killed in Kerala in one of the government hospitals. I mean, she was attending a criminal who was brought from the local jail, I believe, and he was also under the influence of alcohol. So it is not just kappa. I think it is our preparedness to anticipate such thing happening in a emergency department where there is a young doctor all alone managing a patient who is under the influence of alcohol, and he's a criminal who stabbed her and she got killed. I don't know how many of you know about that case. Every time I think of that case, I say it's a system failure. It is not her failure. It's our failure. Why can't we anticipate this risk to our professionals or our healthcare provider? It could be doctor, it could be nurse, it could be anybody. But how can you send a young doctor all alone, girl, managing this patient, in the middle of the night? So that means we need to be more clear about how do we really go about, preventing such things from happening. Yes, Dr. Manjusha, please go ahead.
Thank you for bringing that out. Actually, this is something um, I was want to talk in the lines of what you mentioned. For one, in Kerala, the present medical scenario, we have at least 80 to 90% of the MBBS students, and the MBBS students are girls. Very few boys come into medical education, that is. That is the first thing. So obviously, you're going to find more female doctors around, at least in Kerala. I don't know the situation outside.
Yeah.
Second thing, the protection. I feel all said and done, we have to communicate well. We shouldn't be intimidating, but at some point of time, we have to think ourselves as another human being, another citizen of India, having all the rights. For example, for just an example, we had when I was doing my duty at night, I had my resident and an intern, both females. A grandfather brought his grandchild. The mother is there, father is there, grandfather is there, and she came with exacerbation of asthma. We gave her the nebulizations, and then we were asking them for a second neb and maybe observation. This old gentleman, he started shouting at my junior resident, my intern, the casualty MO who was a female, for no reason at all. He didn't have any reason to shout at them, and he was going on saying about how bad the hospital is and how this that totally unrelated things. And at the end of the day, I had to take the mother of the child aside and tell her, see, if someone comes into your home and does this, would your father and husband remain quiet? No, na. Similarly, I won't be quiet. One more word from his mouth, I'm going to call the police. It took me that to send him out of my ER. Sometimes I think we have to stand up for ourselves and our colleagues. That is what failed in Vandana's case. No one stood up. That is what actually happened there. And let me tell you, ma'am, the moment a mob approaches a hospital, the security is gone.
Yeah.
The auxiliary staff is gone. It's just the doctor and the nurses who are there. We have a family at home. Yes, services. My mother always tells me, don't look for money. It's service. Service is one thing, but then we are all risking our lives to run homes, to have better lives for ourselves and our children. We too have the right to life. So I think some laws like the Hospital Protection Act, which is only in the paper, should be enforced.
Yeah.
If that is the case, then yes, all this patient rights, everything can go by whatever is there by law. And otherwise, there's no point improving on the quality when doctors feel unsafe in their own workplace.
But at the same time, Dr. Manjusha, बच्चा खाना नहीं मांगेगा तो माँ खाना नहीं देगी. बच्चा दूध नहीं मांगेगा तो माँ दूध नहीं देगी. Expecting the system to do something for us is not going to happen. We will have to ask for it in the right way to the right person. Only then change will happen. See, I read a lot of posts on LinkedIn where we talk about the corporatization and doctors feeling being exploited. See, when you are allowing the person to exploit you, then you can't blame them completely. So you have to take responsibility, you have to take a call, you have to take decision. I will take this, I will not take this. And that's how you bring a change. Change is not easy. But thank you for sharing your thought. Thank you. Dr. Santosh, you wish to say something?
I just wanted to second her, and then in many private hospitals, fortunately, they have started having this big number of nurse security staff. So whenever we feel that there are this kind of thing happen, then we at least 30, 40, 50 people. And the whole idea is that patient has to be outnumbered by the number of security staff, but not everybody can afford. Smaller hospitals cannot afford. We wrote a paper on this subject, how to handle this, and so a lot of kind of networking with the police and different professional organizations, private organizations, having nearby network, having this kind of scenario, and of course, with some proper networking and all that communication system, we have to be somehow outnumber those people. And if they understand that they are also at the risk of their life, then probably they will not take those extreme cases. Having said that, everything communication is definitely important. Being a certain is a problem. Sometimes when we feel there is a fear to life, as you said, keeping the policy of two door, so that this policy of having some network professional relationship where we can have accessibility to security is very, very essential.
Absolutely, absolutely. So there is no one-line answer to it. You will have to really, engage a lot of stakeholders to control the situation, and it's always good to have that kind of support system and network to control such situations. Absolutely, I completely agree. So thank you for the wonderful discussion. I think that was so nice to hear your experiences and learn from that. I'm sure it must have been a rich experience for each one of us. I've shared the feedback form. I've modified the feedback form this time because till last session I thought let it be simple, but now I have asked some, longer questions, some longer answers needed. Even if you don't give me now, you can give the feedback by tomorrow. It's perfectly all right. I will share the feedback form link in the WhatsApp group also. So you can but do give your feedback because we want to improve the programs and we want to make it. This session was not there initially, but then I thought no, this has to be part of the program because I want to really give you what is need based, what you can immediately apply or use in your workplace, and that's how I have modified a lot of topics and changed a lot of topics, and I've integrated this topic in the discussion. So
I'm sure when we are dealing with this kind of scenario, though we have been doing it, but yes, some of the principles will come in our mind and then we'll change our approach.
Absolutely. That's what is the idea, that if the mind knows, then someday it will come in action. Someday it will come in your field. That's the idea.
Thank you.
So thank you once again and good night. Thank you.
Good night, ma'am.
Bye-bye.
Good night.